Good evening and welcome. Thank you for joining us tonight for the North Toronto Ontario Health Team's first virtual town hall. I'm Mark Schlossberg and I'm the moderator tonight. The Ontario Health Team is a collaboration of healthcare organizations and providers supporting as a region within the province, and in this case, in North Toronto. And their goal is to improve the coordination and delivery of care so that we as a community can get the right care and easily access it at the right time. It spans hospitals, family physicians, long-term care, and home and community care facilities. My professional background is in business consulting for technology companies. As a family and patient advisor, I get to work closely with two work teams in North Toronto on the health team, patient and engagement and the digital health. And I've been involved in things like the virtual portals, virtual care, patient portals, and with other OHT partners, long-term care, process, and research. Tonight, we have a panel of experts to talk to us about COVID-19, and they're going to cover vaccine eligibility and safety profiles, public safety measures, and vaccine rollout and hesitancy. Our panel is made up of Dr. Jerome Lees, Medical Director of Infection and Prevention Control at Sunnybrook. He'll discuss vaccination rates, concerns you may have about the variants, and a review of the approved vaccines. Natasha Salt, Director of Infection and Prevention Control at Sunnybrook, will cover health and safety measures that we must all diligently follow. Dr. Karen Fleming, Chief of the Department of Family and Community Medicine, will cover the mobile team vaccinity delivery in long-term care and retirement homes. Dr. Iris Gorfinkel, Family Physician and Principal Investigator at Prime Health Family Practice and Clinical Research, will discuss vaccine hesitancy, factors that accelerated the research in the area and its impact on making a choice of getting vaccinated. Dr. Modupe Tunde Bias, Staff Obstetrician and Gynecologist at North York General Hospital and President of the Black Physicians of Canada, will discuss vaccine hesitancy within the pregnant and breastfeeding population, as well as marginalized communities. After that, we'll have a Q&A. If you have questions, you can enter them at the bottom of the screen. We'll do our best to answer them. Now let's get started. Dr. Lees.
Thank you, Mark, and good evening, everyone. It's a pleasure to be with you and have an opportunity to answer questions. And so, Mark, would you like me to just go through some introductory remarks? Because I think Hafsa had also sent me some questions, if you'd like me to go through those.
Well, yeah, you can go through the questions in the context of this.
Sure. So I'll set a little bit of a general high-level context for some of our discussion this evening, and I know some of the subsequent speakers will be able to get into some more details. And my apologies, I have a meeting at 7, which prevents me from staying for the whole session. So I'll start off, first of all, in speaking briefly about where we are right now in the pandemic in terms of the third wave. As people know, it's a very brutal wave. The healthcare system capacity is really, really stretched. And this is why we're working around the clock and really trying to get through it. And I want to emphasize one point at the start, which is that this third wave is being driven mainly by one variant. It's the UK variant that you hear about, B.1.1.7. It basically actually makes up roughly 90% of all COVID-19 in Ontario now. It started as the minority when wave 2 was happening. It was actually really not a factor, and we got wave 2 under control. But we knew this variant had already been introduced in Ontario and was going to become dominant, and it did become dominant in March. And now that variant has emerged, and that's really almost all of the COVID-19 that we now see as part of wave 3. That variant is more transmissible, which means it's more difficult with the previous public health measures that we've used to actually get it under control. And I think people have seen how bad this wave has been in the community. It's also more virulent. And so we've unfortunately seen that it can cause more severe disease. We've seen this in other countries, but now we have data in Ontario showing that but twofold chance of being admitted to critical care. There is also an increased risk of death from this particular variant. And what we've seen is that it has really taken hold in younger populations. We're seeing a lot of younger people become hospitalized, become critically ill. And unfortunately, we've seen deaths in younger people who have otherwise no other previous health problems. So not the typical patients we would have seen more commonly with COVID-19, especially during wave 1, even during wave 2. This is a younger population in general. About half of all of the COVID-19 we're seeing now in the province are really less than age 60. And we're seeing quite a few patients in their 20s, 30s, and 40s in particular in that age span. And we've even seen younger. And of course, we continue to see some older patients as well who are high risk. So there's good news in this. And the good news is the currently available approved vaccines are very effective in preventing this specific variant. And as I said, this is the main variant circulating. And it really looks like it doesn't matter which vaccine you receive, and I'll give you a breakdown in a moment, as Mark requested. The impact of this vaccine is tremendous. What we're finding is that people who have been vaccinated are at far lower risk, not zero risk. So the vaccines don't ever eliminate risk completely. You'll hear the odd story of people who are vaccinated who still became sick and some of them hospitalized. But in general, a single dose of vaccine, regardless of which vaccine you received, whether it's Pfizer, whether it's Moderna, whether it's AstraZeneca, has a greater than 80% or will reduce the risk by over 80% that a person will be hospitalized with COVID-19. That data has been reproducible across many, many countries, and it really shows the impact of even a single dose of vaccine. And then, of course, ideally, some of the people will get second doses as well, which could reduce the risk further, as we'll talk about. And so what we're seeing is that in populations that have had vaccine, 1 dose at minimum, but definitely 2 doses as well, we're seeing far fewer infections. So I want to use the example of long-term care because we all know long-term care residents and how vulnerable they were and how poor their outcomes were, especially during wave 1 of the pandemic. We see virtually no COVID-19 in long-term care, almost none during this third wave. These populations are very protected after the vaccine efforts that were put in place in between December and February. So that shows you the impact of these vaccines. And just to reiterate, it doesn't matter which vaccine you receive in terms of the main outcome of reducing a severe infection, reducing the risk that a person could be hospitalized or die. All 3 of the approved vaccines are very, very protective. Of course, we can't vaccinate fast enough, and that's been the issue with wave 3. And so there's a lot of efforts underway right now to use targeted strategies and vaccinate vulnerable populations and hotspots. That, looking at different parts of Toronto and different parts of the province in those hotspots and trying to target those at-risk populations is a really important strategy that has now been put in place for a few weeks and is making a difference. That'll probably be talked about later by some of the other speakers. But in short, with the public health measures that we have in place that include a stay-at-home order, we've been able to get our what we call the effective reproduction number, but basically the average number of cases or secondary cases from each new COVID-19 cases, we've been able to get that to 1, which basically means that the overall case count that you've been seeing, particularly over the last week, has been relatively stable in the 3,000 to 4,000 range, and it hasn't continued to increase. That's been our stay-at-home order and all of the public health measures that have gone in place, of course, with some of the vaccine effect that we already have. But now, in addition to the continued vaccine efforts, especially in those high-risk populations, It is expected that over the next few weeks, we'll be able to get that effective reproductive number below 1, which means that every new case is generating less than an additional case, and so case counts will actually decrease. It's going to be a few weeks till we get there because it's taking great effort to be able to vaccinate all of these populations. The single greatest limitation of the vaccine campaign, in my opinion, has been supply. It's not been person power, it's not been effort, it's not been coordination. There's been a phenomenal work that's happened across not just hospitals, but our community partners, public health, et cetera, to be in every day vaccinating. And frequently what has happened is we run out, or we have to manage our supply so we don't completely run out, because we can't just open and close. And so we're not going as fast as we could, hoping the supply chain will eventually improve and we'll be able to really have the greatest impact. So the promise and I hope that we need to have is that the vaccine really offers a significant protection to the population. So the outlook is positive because actually, in fact, once we have that supply, assuming people come and get their vaccine, which is the big question and the big must, if they show up and if people get vaccinated at high numbers, we will really transform this pandemic. And after the third wave, when things eventually improve, things will really improve. That's how powerful these vaccines are, all 3 of the approved vaccines. One of the questions that came up, which I think I was asked to answer, was related to, how come we only give 1 dose and defer a second dose? And I thought that in the clinical trials, there was a schedule. People need to get a second dose within a specific time frame, whether it's for Moderna, Pfizer, AstraZeneca. And so I wanted to just spend a few minutes on that particular question because it's come up and it's been, a subject of a lot of discussion. When clinical trials are done, these trials in particular were interested in answering the question, how quickly can we give the vaccine series in order to achieve the level of protection that we need? And so it sort of came up with minimum timeframes that people need to wait to get the second shot. And of course, if we didn't have the vaccine supply problem, we would just follow that schedule because it would allow us to get to the second dose in the most number of people the quickest possible and offer the greatest level of protection as quick as possible. Unfortunately, due to the supply, a different strategy had to be adopted. And so I'll just use a very simple example that is sometimes used to explain it, which is if you had 2 people, and we'll take them as your parents or perhaps your children, whoever you have in your life, 2 people that are vulnerable for COVID-19. I think we all are all vulnerable at this point in time, but 2 people who potentially you wanted to protect. And unfortunately, rather than having 4 doses available, 2 doses for each, you really only have 2 doses for those 2 individuals. You have a simple question. You can actually follow the schedule and give both of those doses to the 1 individual while leaving the other person completely unprotected. By doing it, you've followed the clinical trial information and you'll be able to optimize the protection quicker in the 1 individual, but you'll of course leave the second individual completely unprotected. And so, the question is, from a risk perspective and from a perspective of population health and from a perspective of overall impact and also mortality, so deaths within the population, which is the better strategy? And so the science on this is actually very clear. When you look at giving a first dose to both individuals, I've told you that beyond clinical trials, we have real world data showing a greater than 80% risk in hospitalization and death, greater than 80% across all the vaccines. That's clearly the better strategy. It doesn't mean that both have completed their vaccine series, but it offers them a great level of protection. And you can literally vaccinate twice as many people and offer them greater than 80% protection. Once your supply improves, you can give them their second dose at the latest 16 weeks, but even sooner if doses become available by then. People sometimes wonder, well, is 16 weeks too late? How do we know? Does that mean that the vaccine won't work? And I can assure you that that is not a problem. We have a lot of science from immunology before, and now we have real world data from COVID-19. That first dose, the immunity from that lasts many months. It actually lasts longer than four months. But we've actually, Public Health Agency of Canada was fairly conservative in picking a 4-month window, because we obviously didn't want to leave people with 1 dose for longer than necessary. But factoring in the supply considerations, they decided 16 weeks is reasonable. By 16 weeks, people will still have a high level of protection from their 1 dose, and they'll still respond to their 2nd dose and get a booster from that. And that will be the most successful strategy across Canada, given our supply limitations. And so that was the rationale for that discussion. There's one more point that I'll make, which is that just because you've received 1 dose of vaccine, this will be a segue to my colleague, Natasha Salt. Just because you've received 1 dose of vaccine doesn't mean you can let your guard down, okay? About 1 dose is extremely protective, but it's not 100% protective, okay? And so what I really want to emphasize is we're in the middle of a very bad 3rd wave right now. And despite 1 dose being very protective against that variant, it's not 100%. And so it doesn't mean that people can just go back to business as usual with 1 dose of vaccine. Following our public health measures is crucial right now. And we all have a role to play in being very strict in doing only the minimum essential work, but otherwise it's stay at home. And that will be vital to keeping everyone safe. Even if you've had your dose of vaccine, let that sit, let that work. It'll take a couple weeks to get you to the level of protection. And then, we need to lay low and be very careful as we get out of this 3rd wave. Once the risk of the 3rd wave is subsiding, it will be, we will have opportunity for things to change. 2nd doses will be coming in the summer, which will be across the board. Again, that booster and also higher level of protection across the board. And I think at that point in time, we'll be dealing with a very different situation than what we've known for the last several months. So I'll stop there, and happy to answer any questions or pass it over to Natasha.
Thank you, Dr. Lees. And up next is Natasha Salt with the latest infection control guidance.
Thank you, Mark, and thank you, Dr. Lees. And I'm honored to be part of this panel today. And my focus will speak specifically to some of the public health measures that have been put in place. And I know there's a lot of questions and optimism around having had the COVID vaccine and now what's next, and what does that mean? Can we change our approach? Can we stop wearing masks? Can we start getting together with family, friends, and what have you? And so that's part of the slides that I'll share with you, and answer any questions that you might have. Let me just pull it up here. Can you see my screen okay? COVID-19. Okay. So this is probably the biggest question I get asked frequently, even within our own organization and beyond in the community, which is, can I now take off my mask and let my guard down? And the answer right now, unfortunately, is still no, but I'm very optimistic for the future, and I'll cover some of that as we go forward. So some of my slides here are really just a bit of a placeholder for interest's sake, and this here is a sign I like, a slide I like to share is just all the kinds of different messages that are being sent. Go, stop, do this, don't do this. So it is super confusing. So I will agree with you. If you're confused, it's not surprising. There's a lot of messages being sent, and I'm hoping to really hone in on the strategies in particular that will really still continue to protect you as we ride this wave and hopefully sail into a future of less COVID transmission and a chance where we will be able to start to scale back and reduce some of the public health measures that have been applied. So I do want to come back to this, though. I think this is important. A lot of people look at the activities they're performing and wonder whether or not, there increases in their chances of being at risk for transmission. And this slide I like because it really does show you the gradient of from, very low risk of transmission, you're quiet in an outdoor area, well ventilated. We've all heard that message. You can get out, you can get fresh air, just stay away from groups, and try to stay to yourself. And of course, you can see here that coincides with, much less risk of a transmission. But as you continue to go down into the far right bottom corner, you can clearly see that when you start getting into the shouting and singing categories or poorly ventilated atmosphere areas, that your increased chance of you have an increased chance of contracting COVID, and that's significant, right? So I think you keep this in mind when you're doing any of the activities that you're doing. It's important. So public health measures have also been very nicely aligned with this. You kept a lot of bands, instruments, singing, that sort of thing has really been scaled back because we've seen transmission in those settings where the ventilation's really low, whereas other things have been quite, still low risk, and we're able to even further decrease the risk of transmission with wearing masks and physical distancing. This slide I also really like, because I get asked these questions as well, where, what if someone else is wearing a mask, I'm not? What's the chance? How much does it decrease? So I can't tell you or can't quantify how much the risk decreases, but I can certainly show you this image, which is very clear. And you can see that, two people that are completely unprotected are sharing and breathing the same air, especially when in close proximity, all the way down to two people that are masked. You can see that their cough, secretions, and even, if they're singing or talking, all of that is contained to a very localized area in and around their mask. So when you start to put all these things together, you can see how by implementing these public health measures, we really do have an element of control in being able to prevent sharing our viruses with one another. Another question that comes up quite frequently, especially in and around the time where in the States, the CDC had published some research around double masking. And this is a very popular question around whether or not it's necessary or needed. And really, I still think that when you come back to the basics, making sure you have a tight-fitting mask, making sure that it's covering your nose completely and underneath your chin, and that there's a snug fit. And if it's a medical mask, in particular, you need only one mask. The recommendation and thought process behind the two masks is really when you come to non-medical masks or masks that have not been verified to provide adequate protection. So you get into, double mask, or you get into 2 layers versus 3, which is recommended by Health Canada. And that's where you start to see, well, maybe you should double mask, because it, when you start to add layers, inevitably you're going to create more and more barriers. So it makes sense, but from a comfort perspective, you may not actually be wearing that mask properly if you start putting on 2 or 3 masks. It becomes really hot, difficult to breathe, and people are more apt to touch their mask, which is exactly what we're trying to tell people not to do. So the double masking piece, I'm really sensitive to. I do think if you have a well-fitted mask and it covers your nose and your chin, and that you're following all the other public health measures that are being recommended, you really are substantially decreasing your chances of transmission. Again, here's another pictorial from the CDC again as well, just talking about wearing your mask properly and wearing, again, anything with vents that does not actually contain your secretion. So it's not, we don't advocate for that. And wearing N95 masks, of course, we're trying to protect that supply for healthcare professionals who are engaged directly in high risk activities where there's a lot of aerosols being generated. And so that's important for us to still think about. There are other solutions people have looked at, but the thing is that with some of these other solutions, they haven't been proven necessarily to be adequate ways to protect yourself from transmission. So again, heeding caution, wearing a properly fitted mask, I think is very important. If you have a medical mask, you do not need to layer up. tightening it in some ways by putting different apparatuses to tighten it or tying knots is okay, but some of these other solutions are not necessarily as great. I like this because it just speaks to public health measures. Again, layering up. In the winter, we put on extra garments to keep ourselves warm, clothes to keep us warm. And in this, COVID-19 is no different. The more layers we add, the more we're likely to be protected. And so this is where I created this slide, and it really consolidates all the tried and true public health measures that have been put in place and have been advocated throughout the contents of this pandemic. And I think they still all remain very important. And you can see here, I have Be a Flu Fighter as well. And being a flu fighter, getting your flu vaccine every year is also just as important. The symptoms of the flu or any kind of respiratory infections can mimic and look just like COVID. And so the more we're protected, the more we add in these layers, the less likely we are to come down with something that we think may be COVID, or in other cases, maybe flu. Our flu rates have been significantly reduced for a variety of reasons, including the fact, I think, that when you look at all these measures that we've put in place, we've decreased a lot of transmission in general. And here comes the COVID-19 vaccine. And so we've all been waiting for this, and we're all excited it's here. And, there's still things to be learned about the COVID vaccine and how it'll affect public health measures. I am optimistic that we will see changes in public health measures. Could that be as early as this summer? We don't know. It could be, but the main point is that we all get vaccinated. The public health, scaling back on public health measures is really, really going to coincide closely with herd immunity. Herd immunity being the number of individuals who have received their vaccination and or been infected with COVID and recovered. And the more people we see falling into this category, the greater the likelihood that scale backs will be in place for the protection. So meaning that you might not, we may see, schools reopening. We might see things like more stores opening. You may see things like, recommendations around you can gather more frequently with individuals. Again, I don't know exactly, I'm not going to predict how that's going to look, but it certainly will coincide with increased vaccination and decreasing transmission rates in the community. So that's where I land with my last slide. There is a lot of hope and optimism for the future. And I don't think the future is far. We've been along this path now for quite some time. This COVID pandemic has, January the 26th, we identified a year and a bit ago now, the first case in Canada. It's been a long road, and I'm thankful for everyone in the community who have been very active supporters in heeding public health recommendations. It makes a huge difference when people in the community are heeding these recommendations. We see it, and we see less people coming to hospital. We see less people in our ICUs. So these measures do work, and COVID vaccine here now is the light at the end of the tunnel. So I would encourage everyone, please, it doesn't matter what name brand, it doesn't matter, as soon as you can get that appointment, get vaccinated, and add yourself to the group that's, wanting to come out of this pandemic. So thank you.
Thank you, Natasha.
You're welcome.
Maintaining the health protocols before and after being vaccinated is important for individual and community health. Our next panelist is Dr. Karen Fleming, and she'll discuss the mobile team's vaccination delivery. Doctor?
I'm waiting for my slides.
Okay. There you go.
So it's a pleasure to be here speaking tonight. This is, you know, it seems like only yesterday that we started, that the vaccines arrived, and we started on this journey towards vaccinating as many people as possible. As Dr. Lee said earlier, we will all remember how vulnerable our long-term care residents were and those in retirement homes. And just before Christmas, the vaccine centers at the hospitals came to play. Certainly at Sunnybrook, it opened just before Christmas, and the mobile teams came into play right after that. And together with the long-term care homes and retirement homes, we moved into the community to take vaccine where it was needed most. Next slide. So, you know, it involved a lot of working on the fly, learning to work together, using space differently, because vaccinating this number of people together in different settings was a new and novel. And so working together really helped us to move forward, whether we were working in retirement homes, using kitchen space to draw up the vaccine, working together with retirement homes, long-term care home together to make sure that we had enough staff. We were looking at going, doing some clinics in the typical clinic style in open spaces, and going door to door into families and bringing groups of people together and learning new skills. So I'm a physician, for instance, but here I am in one of those pictures learning how to draw up vaccine, because Pfizer is one of those little finicky vaccines, and wanting to make sure that one does get the amount of vaccine that you need in order to get as many people vaccinated as possible. So it really was you know, a time of hope and optimism to try to change what was happening in the community. And there were a ton of lessons learned over that period of time that helped us move from long-term care to the retirement homes and into other senior settings like the Toronto Seniors Building, where again, going door to door, working together with community partners like Sprint, like other community agencies, where you can really overcome some of the barriers that will stop people from being able to get into some of our hospital-based or mass vaccination centers. So really going where people need to go. Next slide. So once we were able to finish up the long-term care homes and finishing up the retirement homes, what was next on the agenda? So our mobile response team, with lessons learned, moved to other congregate care settings in the community. So places like shelters, places like group homes, taking the vaccine where it needed to be, overcoming barriers, working with people who know how to address vaccine hesitancy, and getting those vaccines where they needed to go, and learning quickly at how to do things differently. So I can't tell you how many new lessons we've learned, and the partnerships that I think are going to last us ongoing in our future in healthcare in the North Toronto area. So there's definitely been some hope of how in the future we're going to learn to do things differently and have a more integrated and connected healthcare team. Next slide. Next slide. So this is one of our local, very close to Sunnybrook. We've had very strong relationships with the Bob Rumble Center for the Deaf, but this was a really, it's so important to be able to work together with interpreters, knowing the residents and bringing the supplies to where they needed to go, and setting up buildings where we've got going door to door, bringing the IPAC team together, and really getting it done as efficiently and as quickly as possible in as comfortable a situation as possible. So having interpreters was really clearly game changing for being able to get things done in the Bob Rumble Center. Next slide. So I would be remiss to not mention the settings that are always there and that are our hubs that we go out into the community from. So in North Toronto, of course, there's the Public Health Vaccination Center that is at Yonge and Eglinton. The two that are associated with the Sunnybrook hub are the bottom slide, which is the Sunnybrook site, where we're delivering vaccine, initially age-based, moving on to the highest risk, and moving forward on that. And that is an area that may be comfortable for people who are coming to the hospital frequently. And then the Baycrest Arena site, which is the Lawrence Engelmount Vaccine Clinic. So this is placed in a community arena. So this builds on good memories that people in the community have had. Who hasn't been there for skating lessons? Who hasn't been there to have a hockey game? It is a place that we are, attuned to and comfortable with. And that clinic is located in a hotspot, an area of higher rates of COVID. And so really allows us to do both alternating between a mobile clinic for higher risk populations, as well as running standard clinics that we book in the usual and standard way. Next slide. So what's on the agenda? Where do we go from here? So as Jerome Lace mentioned, we're really wanting to target the highest hit neighborhoods where the rates of COVID are high, and really trying to blanket those areas with vaccines so that we can address and limit people ending up in hospital and the ICU, and that's where we can have our biggest bang for our buck if we get our vaccines where they need to go. We're continuing to do our congregate settings, going out on road trips, working together with these different settings to deliver vaccine to those who cannot come out and get to where we're going. NORCs, our naturally occurring retirement communities. We know in our community that there are many condominiums, apartments that are filled with seniors. They weren't designed for seniors, but they've turned into this natural retirement community. And overcoming barriers and taking vaccine to where there's a higher number of seniors, it really, again, a bigger bang for your buck, and wanting to go to those specific ones that are located in hotspots. So there's about 458 in Toronto, and 250 something, I may not have that exactly right, are located in these highest hit neighborhoods, and making a concerted effort together with other health teams to try to get in and get vaccinated is important. Homebound vaccinations, these are beginning, and it's a targeted approach with paramedics working together with primary care providers, and family physicians have already told us they know who their patients are. And how are we going to work together with vaccine hubs, community partners, and get those vaccines to people in their homes who cannot get out for a variety of reasons, whether it's medical, whether it's mental health, whether it's lack of ability to get taken, long lineups, for whatever the reason. We know that this group is at high risk from caregivers coming in, and really important to vaccinate the homebound person, but as well their care providers in that space. So I think you can see that we've got a multi-pronged approach. So we've got the clinics that are there, and the mobile teams are going out from those areas. And more to come. All we need is the buckets of vaccine that we're hoping so soon will be arriving, where we can deliver more and more vaccines, so that we can move towards that place of hope and a period where we're not going to be on lockdown. So happy to take any questions, but this really is sort of where we're at right now.
Thank you, Dr. Fleming. So far, we've covered the different vaccines, the rollout, and some health and safety protocols. Now let's switch gears and discuss vaccine hesitancy. Dr. Gorfinkel.
Many thanks for having me, Mark. I very much appreciate it. It's a privilege and an honor to be here, and I hope that it meets its mark. So let me introduce myself. My name is Dr. Iris Gorfinkel. I'm a GP. I'm founder and principal investigator of Prime Health Clinical Research, and I've been at clinical research for a very long time. Next slide, please. This is my disclosure slide, and this is actually a partial listing of the many clinical trials that I participated in. At this point, it numbers over 50. So I have taken money from all of these names you see before you, but it has also helped to inform this other life that I now have, which is trying to bring clinical research to people so that it's understandable. Next slide, please. So in order to understand who we are, we have to understand where we come from. It's hard to believe, but this modern masterpiece is from 1897. And it asks just those questions. Where do we come from? What are we? And where are we going? So if you look at it from right to left, the three women and the child represent the beginning of life. The middle symbolizes daily existence in adulthood, and the far left shows an old woman struggling to come to terms with death. So in order to understand where we are going, we must understand where we have been. And this holds hands with vaccine hesitancy. I have to share with you what you're about to see is not for the faint of heart, as you can well imagine. Next slide, please. So let me ask anybody, I will gladly buy you a box of donuts, if you can tell me what this building is. I'll give you a hint. It was erected in 1930, and it's in Nova Scotia. It's called Shubenacadie Residential School. This is the building children would have seen after having been taken away from their parents. They would have been brought by animal, probably not by vehicle, but it's interesting. The goals of these schools were to fully assimilate Indigenous communities into Canadian society and to thoroughly destroy Indigenous culture, identity, and language. So let me introduce you to some of the people who work there. Next slide, please. It was managed by the Roman Catholic Archdiocese of Halifax. I want everybody to try to look into the face of each of the individuals in this picture. The children in the photo were subjected to harsh discipline, malnutrition, starvation, poor health care, physical, emotional, and sexual abuse, and medical experimentation. That's not widely recognized, but medical experimentation took place in these schools. Next slide. 150,000 children across Canada were removed from their homes. 7,000 children died there. The schools were taught poorly. They were taught in English and French. The children did not speak those languages. They were taught by teachers with no standards and were run by poorly paid teachers without qualifications. Next slide. The last of these schools closed only in 1996, recently. Next slide. Official apology, 2008. Think about how recent that is. Next slide. So let's go back to 1942. So wartime hysteria is mounting, and here's a Japanese family just prior to their transportation to a Japanese internment camp after Prime Minister William Lyon Mackenzie King signed the War Measures Act. Next slide, please. This allowed Canadian authorities to literally seize all the assets of Japanese Canadians, a lot of whom didn't even speak Japanese, and ship them off to internment camps. Next slide. They were kept in uninsulated barracks. This is Canadian weather, uninsulated barracks with cots and coal-burning stoves. The camps were surrounded by barbed wire fences with armed guards. Does this sound familiar? The armed guards actually had instructions to shoot those who tried to escape. Next slide. Official apology, 1988. Next slide. Next slide. In the same year, in Germany, 50%, that's half of the physicians, joined the Nazi Party in search of research and career opportunities. The policy of mass extermination could not have been done and so effectively carried out without the physicians' help. That's important to understand. Deadly experiments were conducted on Jews, children, twins, Soviet POWs, homosexuals, and the disabled. They numbered in the tens of thousands. So when we say the words clinical research, these are things that hold hands with it. Next slide. Here are the doctors on trial at Nuremberg. It was later to be said that the ethics of modern clinical research arose from the ashes of the Holocaust. And is it surprising? Next slide. More on the history of clinical research. Further human experimentation in war crimes. This is the infamous Unit 731 inflicted by the Japanese Imperial Army on men, women, and children. So you might ask, what does this have to do with Canada? Well, they so-called field tested plague bombs on Chinese cities to see if they could start an epidemic. And guess what? They darn could. So this is where we're at. When you say medical research, many people don't realize the details of these stories, but they do understand that one or two or all of them happened. Next slide. Again, here we go. Tuskegee, 1932. The U.S. Public Health Service recruited 600 impoverished, uneducated Black sharecroppers from Alabama. Next slide. They were told they were not told they had syphilis. Instead, they were told they were being treated for bad blood. Next slide. And here is a man being screened for neurosyphilis. Next slide. By 1944, penicillin had become the standard treatment. It was understood that this was curative, and the so-called volunteers were told, they were lied to, that they had been provided treatment. But meanwhile, they continued infecting their wives and children for the sole purpose of just to watch the long-term progression of the disease. The cure was known. Next slide. When did this study end? The study ended in 1972, that late, 50 years later. Next slide. Official apology, 1997. You know, we have a history of shame, we doctors. And I think, you know, we need to own that history of shame in order to begin addressing what vaccine hesitancy really is at the core. Why would we not be trusted? I would suggest that vaccine hesitancy is actually a form of asking reasonable questions, not unreasonable ones. Next slide. Next slide. So when we ask the question, where are we going? It's fortunate that not all research is dark. And in fact, this pandemic has served as a tremendous light. I think when we look back, and even as we sit in it now, where we sit is in a very positive place. But before I go on and talk about, what are those barriers? I actually want to have a moment of silence in a Zoom meeting to think about those who've lost their lives and those who've set the stage for the modern ethics that we now have in clinical research. I thank you for that time. And now I'm going to address just a couple of things. A lot of people are worried about what exactly is accelerated research. Do I have time to go into that? I do. Good. So a lot of people are confused by this very question. They think that research was somehow sacrificed, that the science was not done properly because, after all, we developed vaccines in record time. People do not realize that the way the science is done was exactly the same. Nothing changed pre-pandemic and post-pandemic. The science stayed exactly the same. What did change is that billions of dollars were poured into that research, and we do not hear about the thousands of vaccines that were failures. And there were tens of thousands that you simply never hear about. And what else did that billions of dollars do? It pre-bought the vaccines. Historically, vaccines are not big money makers for pharmaceutical companies. But now what was happening is they had a guaranteed sale. So they did not have to worry about failure. So what we have is not by accident. And where else did the money go? You know, it took a tremendous amount to figure out what you were going to do with those vaccines, the messenger RNA vaccines. How do you package them? How do you get the vials? How do you distribute them? You know, everything, the package insert, it all has to be considered. And then on top of it, the distribution of these vaccines was no small potato. They had to get to every country, they had to get to every province, and they had special storage requirements. So we cannot take any of these things for granted. These are the things that accelerated the research. It was not the science. And in fact, many people don't realize that the clinical trials are actually still ongoing as we speak. The original participants in those trials are still being observed for long-term but rare side effects. So we have safety data on many levels. One of those levels is what the vaccine makers themselves provide us. A second level is Health Canada's own observations of what happens. So people can, and actually patients and their physicians can submit to provinces and territories to let them know if there's have been unexpected or severe side effects. And finally, the big potato, which is the real world data, that's millions of doses. So this is all pretty exciting stuff when you think about it, none of which can be taken for granted. So we have highly effective vaccines. And when we talk to people, what are their real worries about it? Really, they have two worries. What are the side effects? And what is the safety? The safety I have addressed. But the side effects, it's surprising. They're basically the same for all of the vaccines. 2 out of 3 individuals who get those shots are going to get headache and fatigue. 1 out of 3 are going to experience joint pain and fever. And 1 out of 4 will experience nausea. That's pretty much it. And generally speaking, they're mild, but they're not always mild. But when we consider the risks of the vaccine compared to the risks of COVID-19, there is no question where the greater harms lie. COVID-19 has been devastating on every single level, emotionally, physically, spiritually, hospitals, ICU, you name it, it has been hugely problematic. Financially, I don't even know where to go. I don't even know where to start with that. So I hope to answer any questions that you have, and I greatly appreciate the opportunity and look forward to answering them.
Thank you, Dr. Gorfinkel. Extending the vaccine hesitancy conversation, Dr. Modupe Tunde Bias will discuss its impact on marginalized communities and the pregnant and breastfeeding population. Doctor?
Thank you so much. My slides, please. Well, so just to introduce who I am an obstetrician and gynecologist and also the president of Black Physicians of Canada. So these are the reasons for why I'm talking today. Next slide, please. So we know that the Black population constitutes about 3.5% of the Canadian population, which means 1 in 30 Canadian is Black. And majority of people live in Toronto. However, we know that 9% of the population in Toronto, if you think of that, think of the fact that 26% of COVID infection actually occurred in this population, which is staggering. Next slide, please. So we have looked at the unequal impact of COVID-19 in our population. And we know that there's been disproportionate impact on the Black community and also the marginalized community as well. And this is something that has to do with systemic health and social inequities, which dated back to many, many generations. And we know that this is expressed in the social determinants of health, either low income, wealth gap, poor employment, overcrowded housing, and also lack of access to which most Canadians they usually have, but we have to reduce access to that. Next slide, please. So the consequences of this inequity is huge. And if you look at the Canadian statistics, especially the one that was released this year, and where it looked at visible minority and the density within Canada. So if you have a densely area which is formed by more than 25% of visible minorities, and you compare that to an area where the visible minority is less than 1%, the mortality rate from COVID-19 is actually doubled. And that's not surprising because the same data has been replicated in Ontario and Quebec, where the mortality is 3 times higher. In fact, if you look at British Columbia, which out of the whole provinces in Canada has the lowest mortality, but the mortality in the visible minority is still 10 times higher. This is a staggering statistics that could actually be worse if we have aggregated race-based data. Next slide, please. So needless to say, there's a lot of mental effects of COVID-19, even on us physicians, how much more of people who are in the minority group. Depression, PTSD, intimate partner violence, isolation, and even anger, and also frustration. And we can hear that as physicians every day in what we do. Next slide, please. So COVID-19 vaccine hesitancy, as Iris has looked at this very, very deeply. Why are people hesitant? This is a worldwide issue, and it affects every country if you look at their data. And if you think of the fact that the Canadian population, almost 74% will roll up their sleeves and get the vaccine. For the Black community, 77% are not likely to take the vaccine, which is huge. And most of the people in the racial community work as PSWs. And if you look at the data that we're seeing now, the death in long-term care has been greatly reduced because 91% of those people in the long-term care have been vaccinated. But what's shocking is that 48% of the people who look after them have decided either they're not going to receive the vaccine or they have not even received the first dose. So this is an issue, and that's because of the vaccine hesitancy within our community. Next slide, please. What do we do about this? One, we have to think about why are people hesitant? Of course, people are hesitant because of the previous experience, especially in the Black community. They've been subject to non-beneficial research, and they have not participated in research that would have been beneficial to that community because of fear and trust. So what do we need to do? We need to build vaccine trust. We need to continue to talk about why the vaccine is necessary. Beyond that, the social determinants of health is important. So if we fix COVID-19 today, what happens to people in overcrowded housing? We need to start having that conversation now and start thinking about pandemic recovery, not after the pandemic, but we need to talk about it now. We need to improve healthcare. We need to find out why are people hesitant to take time off when they're ill. Of course, the answer is very simple. Paid sick leave, and that's what we've been dealing with now. If you pay people, they would be happy to stay at home. We need to collect race-based data, not to use it against the community, but to look at it in the way to improve some of the issues that we're talking about. and not to blame biological or cultural or genetic predisposition to some of the chronic diseases that we're seeing. It's important to engage the community, and that is what I think is important in our community, to set up vaccination centers in religious areas, barber shop, and within the trusted community leaders. If you use them, you've increased the vaccination numbers, and we have seen this with the flu vaccine in Taibu. The use of cultural vaccinators has been working for our community, and I think it's something that we need to tap into. Next slide. So closing that, this was a position statement that was signed by Black health leaders about COVID-19 vaccines in order to increase and also to recommend the rollout into the Black community, because the statistics is very obvious that the vaccine needs to be given to this community. But I have to say that we need to celebrate the success of the community vaccine program, which has been working. The fact that Black people are now vaccinating Black people, and that actually leads to trust. And that's something that has gone very well with the use of culturally sensitive vaccinators. So I'll move on to my next slide, please. So because I'm an obstetrician, and this is something that I see every day, I was in my office today, and all I heard with my patient is trying to get the vaccine, whether it's important or not, and there's so much conversation, and it's important to preach the safety of the vaccine in pregnancy and breastfeeding. Next slide, please. So if you think about this time next year, like last year, when we had the COVID pandemic, a lot of people didn't want to get pregnant. But as the pandemic progressed, there's restoration in confidence, and we're seeing more babies being born. With more babies being born, we're seeing the insurgence in different variants, whether it's the Brazil, the UK, the Japanese, the Nigerian variants. So the virus is racing us, and we now have so many variants as we have many more pregnancies and babies being born. Next slide, please. So what are the risks of COVID-19 infection in pregnant women? And I think it's important that women understand that they are in a vulnerable group. There's increased risk of admission to hospital, ICU, intensive care, ventilation, and intubation. And from the obstetrical point of view, there's increased risk of having to deliver these women early. Either they go into preterm labor, or you have to do a cesarean section if it's going to increase their cardiopulmonary resuscitation. So is the risk of stillborn and also preeclampsia. Next slide, please. So the question women ask me is that should they even consider receiving the vaccine? And the conversation today is that yes, and yes, and yes. Because pregnant women and breastfeeding women are in the vulnerable group. And the problem is that we did not get this right, because this group were excluded from the phase 2 and the phase 3 trials of COVID-19. But we now know that there's research to show that the COVID-19 vaccine is safe in pregnancy and breastfeeding women. And we need to continue to emphasize that. Next slide. So why do we think pregnant women should get it? And that's the conversation we need to have that line. It is safe, and it's almost 100% effective in preventing the infection, in preventing women from dying, and also developing long-term risk. And if you're listening to the news, in the last 3 weeks, there was a huge influx of pregnant women in the ICU, in the downtown hospital, who are intubated and who are being ventilated as well. So this disease seems to like pregnant women. And traditionally, we give vaccines in pregnancy. We give DTaP, we give flu shot. And this vaccine, it's genetically engineered. This is an mRNA vaccine. So we're saying to women that it is safe to get this vaccine. Next slide, please. So the side effects, very mild. I have received the vaccine and I had mild reaction, just swelling around the injection site, muscle pain, mild fever, but serious side effects, it's rare. And that message needs to be drummed and we need to discuss that. Next slide. So the options available, it's important to give options, but by far the best option is to say that the vaccine should be administered as soon as possible in view of the spike in ICU admission that we are seeing as obstetricians. For women who choose not to get it, of course, they may want to wait for additional information and they are late adopters, or some would prefer not to get the vaccine in the pregnancy or breastfeeding because they feel more comfortable. Of course, we need to support all those decisions, but as soon as possible, if you have the opportunity, we are recommending this vaccine for you. Next slide, please. So what are the risks for developing a severe illness? If a woman walks outside of her home, and most pregnant women are a healthcare provider or they are essential workers. If you live in an overcrowded environment, you're automatically a high risk. If you're also an essential worker or you're overweight, and women also, pregnant women also have medical comorbidities, hypertension, diabetes, lupus, kidney diseases. This would increase your risk and push you into the high risk group. If you're a smoker, or if you're older than 35, or if you're in your last 3 months of pregnancy, you are considered a high risk. And it's important to discuss this with your healthcare provider and go through your risk stratification. Next slide. For women who still tell me, I'm not a high risk, I work from home, I don't see anybody, but surprisingly, they still tell me that they go to the grocery stores. So the grocery store is still where you meet people who have infection and you may still contract the virus. However, if you choose not to get the vaccine, it's important to follow the public health guidelines. Masking, staying away from crowded area, maintain the physical distance, and continue to wash your hands. Next slide, please. So we also often get questions about what happens if I get pregnant after receiving the vaccine? It's safe. You have two options. Either you continue and get the second dose, or if you want to wait. But it's important to assess your risk with your healthcare provider. Whether if you're in the high risk category, it's better to complete the vaccination during the pregnancy. Next slide. So the good news is for people who are still waiting for the research, the paper published in the New England Journal less than a week ago has shown that the mRNA vaccine is safe and the risk of miscarriage or adverse outcome were similar in incidence prior to the COVID-19 vaccine. So, and this is a data from 35,000 pregnant women. So this is convincing. Also, last week, the SOGC, which is Society of Gynecologists and Obstetricians, supports the use of all available vaccines, Moderna, Pfizer, JJ, AstraZeneca. You can take any of those in any trimester of your pregnancy and during breastfeeding as long as it's available. And also in Ontario, it was announced that all pregnant women are in the priority group starting from April 23rd. But I have to say, pregnant women are still having difficulty in accessing COVID-19 vaccine in Ontario, and we need to look at this critically and make it much, much easier for them to be able to get the shot for those who want it. Last slide, please. So my message is that in the Black community, there's disproportionate effects of COVID-19, and we are hoping that we are made a priority, but the community vaccination program has been effective, and I think it's something that should continue. Vaccine is safe in pregnancy and breastfeeding, and pregnant women should plan to be vaccinated. And that is the news. And that's the only way we can get the pandemic behind us so that we can go back to our normal lives. We can see our loved ones. We can go on vacation, and we can also get our economy back. And the news is, without the vaccine, if we don't raise the virus, it will be too late. Thank you so much for giving me the opportunity. Thank you.
Thank you, Doctor. Now it's time to hear from you. The Q&A period is open. I'll start with the first questions. Dr. Tunde Bias, they're for you, the first few. The first two of three are related. And the first one is from your experience, for women who are planning a pregnancy or who are pregnant, is there a preferred time that you'd recommend to get vaccinated?
So thank you so much for such a great question. For women who are planning pregnancy, they have two options. Either they take the vaccine before and complete the 2 doses and then get pregnant. However, you might have received 1 vaccine and then you're pregnant. And what do you do at that time? There is no scientific data that this vaccine causes any miscarriage above the baseline. It does not cause any birth defects, so you can still continue your pregnancy and get the 2nd dose of the vaccine. So I think that's the simple answer to that.
Okay. Related to that, just because of hesitancy, people are saying, is there a preferred time if they're pregnant where you'd suggest getting the vaccine, earlier or later in the pregnancy?
Anytime during the pregnancy, all trimester, 1st, 2nd, 3rd, in labor, after delivery.
Okay. The third question for you, the last of them, is you spoke about marginalized communities and what's being done that you found effective. Are there other things we could do to promote vaccine education and/or access?
Yes, thank you very much, because when you talk about vaccine hesitancy, you need to think about the root cause of it. People are scared. Yeah. People just don't want, there's no trust. People don't trust the government. They don't trust the pharmaceutical companies. They think they're there to make money. So we need to continue to have the conversation and listen and try to educate people to say that we are in the pandemic. These vaccines are safe. So 1, we've got to win and continue to promote vaccine trust. That's number 1. Number 2 is the fact that we're talking about essential workers. Most marginalized people are essential workers. Factory, they work in Amazon. If people are ill, they're not going to come to work. So paid sick leave, it's important. The other thing is also to use trusted community leaders. We've seen that happen. When I talk to my patients and they are from the Black community, some of them will say, oh, we've never been spoken to like that. I think it's just a natural affinity. So, and that's what we're seeing with Black people vaccinating Black people. So some of the success program is because of that. People kind of trust the people who look like them. So that's another thing. The other thing is also to take advantage of the community. And this has been done in the States. Open up the churches, get the pastors to be vaccinated so that they can ask their congregation to receive the vaccine. Same in the mosque as well. And if you look at where do the marginalized people congregate, barber's shop, if we have enough vaccine, we need to look into that and try to get as many people as possible. And then we also need to hit the social media. There are lots of things on the social media. So we need to go there and continue to promote vaccine trust in the social media. We cannot tell people not to be to distrust But we want to also get there with good news and to tell them about the safety of vaccine. And if, more importantly, if you have a lived experience person, it sure works. Storytelling works in increasing vaccine trust. Thank you.
Thank you. Dr. Fleming.
I'm sorry, I have to leave for another town hall.
Yes. Thank you for attending tonight and putting in the effort to deliver your presentation. Thank you very much. Dr. Fleming, do you have a sense of when pop-up clinics will be made available? Do you have any perspective you could share on that?
I have to unmute myself. A challenge and unfortunate theme at the moment is the amount of vaccine, but there's plans for having pop-up clinics in our local area, and in fact looking at how to address some of the access issues for pregnant patients, and working with midwives, family doctors who deliver, obstetricians, and trying to increase access quickly for the vaccine appointments. So if only we had more vaccine, but I think we're poised to get that moving in the next week or so. So stay tuned. It will be widely circulated and available, but our wings are clipped at the moment with the amount of vaccine that's available.
Okay. Dr. Gorfinkel, how do you talk to someone who's hesitant about AstraZeneca, and what strategies should we use?
It's always good to ask, where are you coming from? What are your concerns about it? It's tempting to just leap right into VIPIT, that very rare blood clot, but it may not necessarily be that. Let's assume for a moment that it is. Depending on whom you talk to, Health Canada pegs it at 1 in 250,000. The World Health Organization puts it at about 1 in 100,000. Whichever you believe, explaining VIPIT is important. We cannot ignore important safety signals, but when we look at the risk of not treating, it's far greater. So that's the issue. And basically any medical decision comes down to that. It's a comparison between what if I treat or what if I vaccinate versus what if I do not. And in the situation, the what if I do not is far greater. VIPIT is a whole category by itself, but essentially what happens is that platelets, which normally form scabs, instead abnormally clump together and block critical veins. And when that happens in the brain, blood can't drain out from the brain, and that causes severe headaches, visual changes potentially, a loss of speech, seizures, and lethargy. And I'm not talking about the usual headache. This is a terrible headache, and it's persistent. So most doctors will never know another doctor personally who's even seen a case. So most doctors might have up to 2,000 patients in their practice. I don't have quite that many, but you can imagine over 50 doctors, you might have one case, if you believe the World Health Organization, of 1 in 100,000. The likelihood of being struck by lightning, quite literally, is around that number.
Thank you. You mentioned that the original studies being done in preparation for the vaccines being approved are still going on. Is there any sense of that long-term research that you can share?
The sense is this, is that they're randomized control trials. And what that means is that half of the patients in those trials received a placebo vaccination, which is an inert one. And the other half received at that time, the investigative product, the vaccine that we now have. And why that's so important is because the kind of data that gives us is called baseline data. In other words, what would happen in the group if they just got the placebo? And that's why they didn't see those blood clots, because they're so rare, you're not going to pick them up with that few of patients. But there could be other things. So they're watching very carefully to compare the placebo group to the active group. And that's how they can see what particularly the active vaccine may be associated with. So far, there have been no serious safety signals identified in any of the clinical trials.
Okay, thank you. The last question I see is for Natasha. And that is there any other recommendations you would suggest given the growing number of variants? We're now dealing with B117, but there are others that the press is harping on. Is there anything else we should do from a safety protocol point of view?
No, I think the problem is that we're just all getting fatigued, obviously, by COVID. And so we're letting our guards down. And this is exactly the moment that COVID's been waiting for, is this, opportunity to get us when our guard is down. And so we do know that the measures, the control measures, even without changing anything, the same control measures that have been used throughout this pandemic and have been recommended continuously by public health are still the same measures that work very effectively against, any new variants that are coming our way. It still remains a respiratory virus that's transmitted similar to the way that the cold is every single year. This probably is around to stay. It's not behaving that much differently than things like the flu, where every year we see that there's variation in the vaccine that's being provided because it's based on what the most commonly circulating strains are, and the more tightly that we can match our vaccine to the circulating strains, the more effective it is. So I do not think anything new or novel has to be applied in this context. Just really hunker down right now. If I could say anything else, hold tight. The storm is still here. It will pass, and do your best to try and comply and avoid crowded spaces, avoid all these same public health measures that have been ringing in the back of our ears all the time.
Thank you. Before closing, I'll just ask the panel if there are any other last comment you'd like to make. Go ahead, Dr. Gorfinkel.
Thank you so much. I think that we have to mention the possibility that this virus may be spread in a way we did not understand before. And that's by something called aerosols. The same way that cigarette smoke hangs in the air is a very strong possibility for this virus. According to Health Canada data, over half of people who contract COVID-19 do not know where they got it. And it may well be that it's these aerosols or microparticles that are in fact spreading it. So for that reason, if you live in an apartment building, it's a good idea to open the windows if you can, and keep the doors open, which is probably a pipe dream. If you have a fan or an air conditioning, do not put that on your face, because basically that's keeping the virus aerosolized. For building managers and janitors, they need to clean the vents and run the fan at low speed at all times. These make a difference. People in neighboring apartments have gotten infected when one person is infected. We cannot ignore that data. And I think that there are simple things that people can do on their own to try to prevent that. And don't forget, with the new variants, they are not just a little more contagious, they are far more contagious. And that's why the mitigation after vaccination matters a lot. No, we're not out of the woods. And yes, when everyone else is vaccinated, that goes a long way to protecting me. The vaccines do protect against variants, all the variants, although not to the same degree. But if enough of us are vaccinated, we will be able to prevent the transmission of this virus on a population basis.
Thank you. All right, then. I'd like to thank the panel for taking the time out, one, to prepare. Oh, one more comment, Dr. Fleming?
I was just going to comment that, the vaccines are going to be coming to the hotspots. So look out and watch for when that is coming, and encouraging the pregnant and breastfeeding women to reach out to their providers, because we are making spots available and trying to match women to those spots as quickly as we can. So reach out, ask if you're having trouble. We can help you.
Great. I'd like to thank the panel for taking the time, one, to prepare for tonight during your unbelievable schedules, and two, to come and present. To the North Toronto community, thank you for your engagement, your dialogue, and your time. We hope that tonight's discussion was both informative and meaningful. From my point of view, after hearing everything, and I'd say stay well, stay positive, and when you're eligible, please get vaccinated. Good night.